Hello guys, welcome to our channel. Today we will be discussing of the medicine rapid revision. This is one of the most important topics and subject for your Fmge examination. So let's start the discussion guys. Those who are new to this channel, please do subscribe and share with your friends. If you want to avail the notes, please do join in the Telegram group and text me in the Telegram. So let's start the discussion guys. So before we start the discussion, we will be discussing one of the most prominent and the remarkable person of this field, that is none other than Tinsley Harrison. So you all might have came through with the Harrison's textbook of our medicine, which is one of the gold standard for the worldwide. The most of the physicians medicine faculty will be using that textbook. So that is one of the best textbook that is authored by none other than Tinsley Harrison. And throughout his career, he only focused on the medicine, pathology, and also pathogenesis, symptoms, treatment, and whatever the maps that we see. What is the next step, next step, next step? This is all discovered. Is came from the mind of the Tinsley Harrison and his followers throughout the all the editions that we are seeing today. So let's start the discussion, guys. So I have divided the medicine into two parts. Okay. So part one, which will we are going to discuss now about the neuro and GI. GI is also contents of the hepato and endocrine. Okay, and also some of the miscellaneous topics of the hemat. So hemat I already discussed in the chapter of the pathology, but some points we will be discussing here also. So if I say this itself is going to have the 10 plus question, so don't give up. Next part 2 tomorrow, which I am going to upload, which consists of the ECG, minimum 3 questions in the examination, and followed by the cardiovascular system pathology and respiratory system. Okay, respiratory system, and also renal. Okay, this is at least 10 questions. So I just said it can be 30 questions. Then whatever the other 10 questions. So the other 10 questions can be mixed back, which is integrated with your pathology, physiology, and also pharmacology. So don't give up. 30 plus questions from medicine is damn sure from the examination. So don't give up. Medicine is not a tough subject. Medicine is a easy subject and you can make it. So let's start the discussion. So first we'll be discussing of the most important topic, that is headaches. Okay, that is headaches. So when I say whoever the patient is suffering from the headaches, we all know that headaches are two types. Okay, one is primary type. Okay, and other one is the secondary type. So secondary type is the most common. Even we also, whenever we feel the fever, okay, fever, we will be having the headache. So acute febrile illness is a secondary cause of the headache, which is most common in all the patients. That is the first point. Now we will be discussing and differentiating between these three important primary the headaches. So one by one, let's discuss. So the most common overall is the tension headache. Overall, the most common is secondary. But when I talk about the primary, in that overall, the tension is the most common. Second most common is the migraine, and third most common and very rare cases, especially in the Western countries, we see this cluster headache. Next, let's start the differentiating. We will be differentiating in the three different categories. Let's say with the gender. So this is most common in the females, especially in the 20s or the 30s decades. And this is also most common in the females, which is more than 30s decades. Okay. And cluster headache, this is most common in the males. Okay. This is most common in the males. And this is also going to see 30s and the 50s decades that we are going to see. And coming to the how the presentation, so this is tension headache, which is a bilateral, and the patient will tell like he will be feeling like a band like pain that is going to be seen in this patient. Next, coming to duration, how many duration it can be. So it is more than 72 hours. So more than 72 hours means it is almost more than 3 plus days. So the patient will be having, at least when he is coming to us, the 1 week history will be told by the patient. Next, migraine headache. Migraine headache is also mostly bilateral, and especially in the early stages, it is going to be unilateral headache. And how it is going to be? It is a pulsatile headache, because we all know that the migraine pathology is in the cerebral vessels. So it is going to be pulsatile headache, and patient will be telling that something is throbbing on her head. So these patients, the most of the times, this is less than 72 hours. And episodic, this is not a continuous, this is a episodic and recurrent type of the headache. And cluster headache, cluster headache is also going to be unilateral type of the headache and very specific headache. Okay, unilateral and very specific location the patient will be telling us where is the uh, headache will be presented, and this is less than 1 hour only, right? This is how we are going to differentiate based on the how the patient is presented to us. Next, what are the precipitating factors? So it could be due to stress, okay, it could be job, it could be love, or it could be anything, right? Divorce, all this will be comes under the stress factors for the patient to have the tension headache. Next, coming to the migraine headache, it is mostly the patient might be having female. Femaleness will cause the more, and also patient age, patient lifestyle, sedentary lifestyle. Whoever using the OCPs can have the severe, and also family history, genetics conditions can be caused, and also the patient whoever is having the anxiety issues from the beginning. This is also going to cause this one. And whoever is taking NO foods, NO rich foods, because that dilatation will cause, and that dilatation will compress the structures, surrounding structures, and the patient can trigger with the pain. That is what migraine is also seen. Next, coming to the cluster headache. Cluster headache will be associated with the seasonal changes. Okay, it is going to associated with the seasonal changes. And whoever is taking the alcohol, and also cold weather, AC or the refrigerators, air conditioners, that can also cause this patient's coldness can also trigger the cluster headache. And how we are going to treat? So for the treating of the tension headache, the best early drug that we can give for this patient is the NSAIDs. For example, naproxen you can give. And for the patients of the migraine you can give depends on the patient presentation. So let's see. So before we have to know about the patient, we have two types. Okay, so one is the classical migraine, means the patient will be consisting of the aura, and second one is the unclassical type. This is no aura which will be seen. What does mean by the aura? Aura means there is a something that going to tell us, okay, I'm going to have the pain. For example, floaters, photophobia, lacrimation. All these symptoms are known as a aura. Or sometimes patients is feeling nauseous before the headache. So that is what classical headache. And if you have to choose which is better, so the most common is unclassical type only, because most of the patients doesn't know what is aura also, but the most of the times they will be presented without aura. And without aura means that patient is having very mild. So in the mild stages, still I'm going to give the NSAIDs. Okay, but if it is a severe, or let's say this is a moderate to severe, for this patient I'm going to give the triptans, sumatriptan, lumatriptan. These drugs can be given for this patient. That is a triptans. And question that is asked: can the pregnancy patients have? In the first trimester, I am not going to use the triptans, but in the second trimester, I can use. In the third trimester, also depends upon the patient presentation. Okay, before whenever you start the triptans, you have to rule out the other conditions like eclampsia also in the pregnancy patients. Next, in the patients of this condition, here I am not going to give any drugs. Rather than the drugs, I am going to give the oxygen therapy. For this patient, I am going to give the oxygen therapy. At least 12 liters or the 10 liters can be given for 2 to 1 hour. That has to be given. This question is also asked. Next, coming to the prophylaxis. So prophylaxis, why prophylaxis important, guys? Prophylaxis can decrease the chance. So for this, I am going to use the amitriptyline. So, okay, here I am going to use the amitriptyline. For this patient, I am going to use the propranolol. Propranolol is a drug of the choice that I am going to use. And here in the propranolol, in the acute stages, I am going to use the steroids. Okay. In the chronic, if it is a recurrent and chronic, then I am going to use the verapamil CCB drug we can use for this patient. So this is what three most important types of the cluster headaches. Next, we also have the sunk and sunt and suna, right? So this is associated with conjunctival tension or the autonomic symptoms, but this is associated with less than seconds only. So 180 seconds, just sudden trigger, the patient will be having this headache and the patient will be decreasing by themselves. For this patient, if they are came in the early, you can give the lignocaine, but most of the time 180 seconds means it not basically it is just a 3 minutes, right? So we can't be most commonly seen. This is the Sankt Arsuna, very rarely seen, which is associated with the trigeminal neuralgia. Okay, that is a miscellaneous condition that you can just remember. Next, coming back to the aphasia. Okay, so whenever we say aphasia, either it could be depends on how the patient is presented. Is the patient is defective of the naming, which is familiar to pen, pencil, all these are familiar. But is the patient is having problem with that, or the patient is having problem with the repetition? Okay, whatever the other person is telling, this person is unable to tell. And is the patient is having the fluent aphasia abnormality, or the patient is unable to understand, the comprehension is defected. What is the defect in this patient that you have to take note before you have to understand? Next, what is the most common type? So the most common type of the aphasia is anomic aphasia. Okay, anomic aphasia. Anomic aphasia means the patient cannot name. Okay, so the naming is disturbed here. In which conditions you are going to see? Especially post trauma. Even in the movies also you see post trauma patient. The doctor will come and tell this patient can't remember anything. We will try our best. So that is what post trauma patients you are going to see anomic aphasia. And what is the structure you are going to see here? This is known as a Broca's aphasia, and this is the Wernicke's aphasia, right? Sorry, Wernicke's area. And what are the importance of this Wernicke's and the Broca's? So the Broca's is present in the which location? Let's differentiate both. Here we will be discussing of the Broca's and Wernicke's. These two questions can be asked in the previous FMG examination only. There is a question on this too. First, Broca's aphasia is present in the frontal lobe. Okay, frontal lobe. More specifically, it is present in the inferior gyrus. Next, Wernicke's. Wernicke's is present in the temporal lobe. Temporal, it is superior. How? See, this is the temporal lobe, right? And how where it is present? It is present in the superior. So this is the frontal lobe and parietal, and you can see this is present in the inferior lobe. That is what Broca's and the Wernicke's. So Brodmann's area. What is the Brodmann's area for this? It is a 44, and Brodmann's area it is 22. So Broca's aphasia is in the frontal. So if frontal is involved, it is going to involve the motor symptoms also. In the Wernicke's, the motor symptoms are not seen. Motor symptoms are not seen here, and the patient here is associated with the non-fluent aphasia, and here it is associated with the fluent aphasia. Okay, the defect name I am telling non-fluent and the fluent aphasia, but the defect that we are looking here. So the patient is blabbering, unable to sound proper, but the patient is able to understand but can't tell us what he wanted to tell, right? That is what present in the patients of the blabbering sounds. Okay, unable to recall, unable to recall, and whatever he's speaking which is not understandable, that is what's seen in the Broca's aphasia. And in the Wernicke's aphasia, the patients which will be telling of the neoglossism, because the comprehension is defect here, so the patient can't understand what he's telling. So the neoglossism, he will be using the new words, okay, and word salad, different kinds of the words he will be picked up suddenly, and which doesn't have any relevance to asking the question by us. So this is what's seen in the Wernicke's aphasia and Broca's and the Wernicke's. Next, coming back to the what is the artery that is involved here? So artery that is passing here, if you can see, this is how the artery is passing, and this artery is known as a MCA, middle cerebral artery. So the branch that is going down, this is the inferior, this is the inferior MCA, and the branch that is going upward, this is the superior MCA. Okay, so inferior MCA is for the Wernicke's, and the superior MCA is for the Broca's. Right, this is the two important points that you have to take note. In the recent INICT examination, there is a question on the emotional prosody. What is the location? Most of the time, emotional prosody, what does it means? For example, someone is asking you how are you, and how you are going to tell? You don't just tell what do you want, you don't tell, right? You will tell I am fine, how are you, like that. So this expression is known as a emotional prosody. And where it is present, it is present in the right hemisphere. Okay, non-dominant place it is present, right hemisphere it is present, and especially this is present in the inferior part of frontal gyrus. Inferior part of the frontal gyrus. This question is asked in the recent FMG examination. Next, moving to the stroke and hemorrhage that we are going to look for the patients. So, whenever I say hemorrhages, the most common type is the SAH, subarachnoid hemorrhage, and some other, that is EDH, SDH, and also intracranial hemorrhage. This is what we are going to discuss. But the most common is the subarachnoid hemorrhage. Next, two important points about this here. So this is the condition of the epidural hematoma. This is the subdural hematoma. So the differentiate between the epidural hematoma and the subdural hematoma, we have been discussing this in the surgery, FSM, and many other places. So that much important it consists. So this will be involving of the middle meningeal artery. Okay, middle meningeal artery, and this will involve the bridging veins, and here the sutures is not crossed, and this will cross the sutures. This is associated with the trauma, and this is also associated with the trauma and other causes also. And lucid interval that is present here, the lucid interval is not present in this patients. So best investigation of the choice is NCCT, and here you are going to see this shape, idli shape. The most commonly they call this is as a idli shape or the biconvex shape, and S for subdural, S for sickle shape. This is what's seen in the subdural hematoma. Okay, concavo convex shape that you are going to see. And what is the treatment of the choice for this patient? So the best treatment of the choice for this patient is craniotomy, same as here also. Here also you are going to perform the craniotomy for this patient. So this is what EDH and the SDH that we have discussed. Next, moving on to the most important condition, that is the stroke, internal hemorrhage. But before that, I say there is a subarachnoid hemorrhage. Subarachnoid hemorrhage. In the subarachnoid hemorrhages, the patient will be having the symptoms such as headache. First one, this is the headache. And how this headache is presented? Thunderclap headache. This is presented as a thunderclap headache. And patient will be also having the nuchal signs. So neck rigidity is also seen. So meninges is also involved in this patient. What is the most common risk factor? Hypertension is one of them. AD, PKD, okay, autosomal dominant polycystic kidney disease can be seen, and also trauma. And what is the most common artery that is involved? So the most common artery that is involved is the anterior communicating artery. Anterior communicating artery that is involved. Investigation of the choice, again NCCT, and the treatment is embolization. Okay, by clipping or any other possibilities we can do embolization, but most of the time the patient will not be surviving. So this is what the subarachnoid hemorrhage. Next, moving on to the intracranial hemorrhages. That is divided into the two types. We can see this is the ischemia type, and here this is the ischemia type, and here it is the hemorrhagic type. These are the two types that we are going to see in these patients. Which is most common? Ischemia is most common. Which is more better if you have to choose? Again, ischemia is the more better, because once the hemorrhage is caused by the rupture, very rarely the patients will be surviving. Most of the patients are brain dead within some days. So that is what hemorrhagic stroke, which will be the patients will be presentation, right? Next, coming to the stroke, what is the most common risk factor? So the most common overall risk factor is the hypertension, uncontrolled hypertension, non-compliance of the hypertension, or the patient who is undiagnosed with the hypertension. All these patients will be the only cause that could be hypertension, or aging, patient age, patient sex, like males are more prone, associated other condition, diabetes mellitus, atrial fibrillation, and the genetic predisposition, okay, familial stroke history, that is also seen. All this will be, and even the lifestyle changes such as smoking or the patient who is suffering from the obesity and also alcohol. All this will be seen. And if ever the genetic conditions is seen, so patients who is suffering from the Down syndrome can have very rarely, and also there is a homocystinuria. This is also seen in the patients of the stroke. And very commonly nowadays we are seeing even the stress. This stress can also cause the stroke in the some of the patients. Let's see. So how the patients will be presented, how you are going to differentiate. So most of the patients you have to take note about the warning signs. This is what used by the Western countries. Be fast. So if ever the patient is having the loss of balance, if ever the patient is eye symptoms like blurred vision, or the patient is having the facial drop or the facial uneven smile or the facial asymmetry, patient is having the arms swinging or the legs swinging, or the patient is suffering from the speech difficulty, you have to time to call for the SOS. Emergency has to be alerted as soon as possible. Why this is important, that we have to go for the patients whoever is suffering from the stroke. Why? Because we have the specific score, guys. This score will tell us how much is the risk factor that the patient is suffering from. So if ever the patient age is more than 60 years, this is a considerable risk factor. If ever the patient is having the high BP, and also as we discussed, that is a clinical symptoms is seen in this patient, diabetes mellitus type 1 or the type 2, and also how much is the duration. Why we are paying the more attention to the duration? Because our treatment is also going to depends on the duration only. So that duration that we have to take note so that we can treat as soon as possible. For example, let's say less than 24 hours. Just patient is having the mild symptoms. Okay, only the warning signs. Hypertension is seen, some of the facial symmetry abnormality, speech difficulty seen. So, but patient is significantly not affected. So this is known as a TIA, transient ischemic attack. This is just a warning. Or the patient is having more than 24 hours, or patient is having the sudden loss of balance, okay, with consciousness. This is seen with the ischemia. This is seen with the ischemia. Most common, that artery that is involved is the middle cerebral artery. Next, so timing here, just remember sudden loss of balance. Next, suddenly the patient is having seizures, loss of unconsciousness. This is the hemorrhagic. And in the hemorrhagic, this is involves the putamen. So putamen is involved, and lenticular nerves or the vessels, that is lenticular artery, that is involved in the putamen region. So how can we differentiate the patients? First, let's say that the patient is came with the bleed, and we have to check, rule out, is it the ischemic or the patient is came with the non-ischemic or the hemorrhagic type. So how we are going to differentiate? All the patients whoever is complaining with of these symptoms, stroke symptoms, they have to go under the NCCT. Okay, why NCCT? Because you have to rule out EDH, okay, SDH. After that only you have to go for the other diagnosis of this patient. Let's say this is negative, there is no ongoing bleed that is visible. So that means obviously the patient is having the ischemic attack. So for the ischemic attack, if you want to further know, you are going to do the CT angiography. CT angiography we are going to provide, and after the CT angiography we are getting to know which vessel is involved in this patient. So that is how we are going to follow the protocol. So the first initial investigation is the NCCT, and this is the second line. But there is a question that is asked previously, what is the better or what is the best? Then you have to choose the diffusion weighted MRI. Okay, then you have to choose the diffusion weighted MRI if it is asked only best. If they ask what is the Next step, then you choose the NCCT. Don't choose the diffuse weighted MRI because we don't do that. That is very rarely is done. Whenever the patient is having the transient ischemic attack, if the patient is affordable, then you can go for the diffusion MRI. But unless or until we are going to do the NCCT because it is a very small procedure, diffusion weighted MRI, which will take almost more than 1 hour. So that's why we are not going to proceed with that MRI. Next, how you are going to treat. So the treatment of these patients is also depends on the time because we're stretching on the timing itself. Let's see what is the time. So let's say the patient is presented at our hospital less than 6 hours. So for this less than 6 hours patient, what we can do? Okay, if the patient is involving only one third of the MCA, one third of the MCA territory in the brain, we can go for the treatment of mechanical thrombectomy. Thrombectomy can be done. But in the government hospital, this is a very costly procedure, means time consuming because there is a very limited resources. We are not going to proceed for the mechanical thrombectomy. But luckily the patient is came even faster, less than 44.5 hours. Then we have to check whether the patient is having any active bleed. No, there is no active bleeding. And is the patient is more than 18 years of old? Yes. The patient BP is not exceeding more than 200 mmHg, not more than 200 mmHg and 90 mmHg of the diastolic. And patient is does not having the cerebral edema. No edema is seen in this patient and no recent history of the bleeding. No recent history of the bleeding. So this is the ideal person for my thrombolysis thrombolysis for the patient's treatment. And these thrombolysis is one of the best which can be used by the etiplase is a drug that can be used for this patient. So this is what more than less than 4 hours. But unfortunately, the patient is came more than 24 hours. But here we can't save this patient. For this patient, you have to start the dual antiplatelets therapy and physiotherapy for the irreversible damage. So this is how the treatment protocol is done for this patient. And some conditions, the thrombolysis is contraindicated. So contraindications for the thrombolysis, patient is less than 18 years old or the patient is having some of the bleeding disorders like hemophilia, DIC, this condition, patient is suffering from the pelvic ulcer disease or the patient is on the menses, especially females, patient is having the recent GI surgery. The GI surgery is less than 21 days because somewhere there is a non-healed ulcers will be seen and patient is having the surgery less than 3 months or the patient is having the recent stent placement. So all these conditions, it is contraindicated for the patients to have the thrombolysis. So, okay, this is the thrombolysis.
These are the important
contraindications.
points and the
So this is the
diseases that we
stroke
have
protocol,
to
guys.
remember in
Depends
this
on the
condition.
timing,
Those who are
depends on
new
the
to this
patient
channel, please
presentation.
do
You
subscribe.
can choose the option, right? These are the important points. Scoring, ABCD2 scoring is also asked in the previous examination. Next. So another picture that you can see, the patient is suffering from the myasthenia gravis, and here the patient is Lambert-Eaton syndrome. They both have sat to eat this lamb. Who is going to eat this lamb in the dinner? So at dinner, 8 p.m. So the lamb is ready to eat. Okay, lamb and lamb. So for example, lamb and the lamb. So lamb eaten patient can eat the lamb at the 8 p.m. But myasthenia patient cannot eat. So why? So let's see the defects, how the patients will be presented. So Lambert-Eaton syndrome, this is a neuromuscular junction disorder. It is a presynaptic condition. Okay, it is a presynaptic condition. And this myasthenia gravis is a postsynaptic condition. Okay, postsynaptic conditions. In the patients of the Lambert-Eaton syndrome, so the defect is voltage-gated calcium channels. These calcium channels is defect in these patients, and they follow the diurnal variation. What does mean by the diurnal variation? So the patient at the daytime is inactive, okay, unable to do the muscle work, and patient at the night is active. Why? Because calcium channels in the morning is more resistant than in the evening. So in the evening, the calcium channels are open. Next, Postsynaptic myasthenia gravis, this is actually an autoimmune condition where the antibodies are attacking the acetylcholine receptors. So though there no acetylcholine receptors is opening, so there is no nerve potential. So the patients will be suffering from these condition with the antibodies attacking the acetylcholine receptors. So in the daytime, these patients will be inactive because attack is more immune response, and in the night, so the patient can have this is the opposite. I'm sorry. So in the daytime, the patient is more active, and over the time, they consume all the acetylcholine receptor, whatever presented, remaining all are already dead due to attack. So by the night time, there will be inactivity in these patients. And what is the treatment for these patients? So what is the conditions associated? It is associated with the lung cancer, especially small cell lung cancer, and here it is associated with the thymoma condition, and treatment and drug of the choice for this patient is a 2,3,4 diaminopyridine, and here the patient treatment is the pyridostigmine that has to be given for this patient. Another important points about the myasthenia gravis. So myasthenia gravis patients, this is the most common autoimmune neuromuscular junction disorders. It can be very chronic also. It involves the females and males also, and it is a type of type 2 hypersensitivity reaction. The antibodies is attacking the receptors, and there is a association. For example, females in the 20s and males in the 50s, who is going to have the good prognosis. So these patients will be having the good prognosis, and these patients will be having the bad prognosis. And what is the antibodies that is involved? Acetylcholine receptors, musk receptors, okay, acetylcholine receptors, musk receptors, and lipoprotein lipoprotein 4R receptors. This is the most common overall. This is what the patients will be presented. And first and foremost symptom is going to be ocular. So first and foremost is the ocular, that is ptosis. And severe muscles will be involved, even the facial also. So sensitive test. So sensitive test is a nerve conduction test or the nerve fiber test. Specific test for the myasthenia gravis, this is going to be antibodies positivity. So hydrophonium test, tensilon test, icepack test they are just test only, but they are not as important as other symptoms. Next, another condition that you can see. What is this condition, guys? The person that you are seeing here is the uh, Stephen Hawking, right? He is the Stephen Hawking scientist. So he is suffering from the aminotropic lateral sclerosis. Aminotropic lateral sclerosis. These aminotropic lateral sclerosis involving upper motor neuron, not just the one neuron, it involving the upper motor neuron and also lower motor neuron that is involved. And it is a type of degenerative disease. It is a type of degenerative of the diseases, and most of the times it is a sporadic condition. It is a sporadic conditions, and this involves the gene SOD, calcium, and the zinc channels that is involved. This question is also asked. SOD is involved in which condition, and what are the involvement that is seen here? So it will be involving of the anterior horn cells of the spinal cord, cortical fibers, cortical fibers, and cranial nerve nuclei. All this will be involved in this patient. And how these symptoms? These are asymmetric, and patient will be having the fasciculations because both are involved, right? And patient tone is completely decreased. Patient tone is decreased here, and more of the distal muscles are involved in this patient. And what is the treatment of the choice? The best treatment of the choice for this patient is the Riluzole. Okay, Riluzole is a drug of the choice for this patient. So this is what the patients who is suffer from the condition of the aminotropic lateral sclerosis. Next condition that I'm going to discuss here is the multiple sclerosis. Multiple sclerosis is also a type of degenerative disease, right? This is also a degenerative disease and autoimmune condition. Autoimmune condition, very chronic condition. It will be involving of the oligodendrocytes in the CNS. Oligodendrocytes is involved in this patient. And multiple sclerosis patient, it will involve the spinal nerves less than 3 segments, and it will cause the unilateral optic neuritis. So cranial nerve involvement is also seen, and the antibodies that are MBP antibodies that is involved in this patient. So this is what the history of the multiple sclerosis, autoimmune chronic condition. Two phenomena that you have to remember here is the Unth phenomena. Okay, Unth phenomena. So what is mean by the Unth phenomena? So the patient is very heat sensitive. Even if we get the just flame, so the patient pain is aggravated. Patient pain is aggravated. Next, Pultrich phenomena. So what is this Pultrich phenomena? So the patient is actually 3D view. So generally we don't have the 3D view, but this patient is having the 3D view. That is what the Pultrich phenomena. And criteria we use is the diagnosis is the McDonald criteria that you are going to use. On the MRI, you are going to see the Dawson finger appearances. MRI, you are going to see the Dawson finger appearances. On the CSF analysis, or you can say IG analysis, immunoglobulin analysis, you are going to see IgG with the oligoclonal antibodies. Oligoclonal antibodies that is presented. What is the treatment of the choice? Prednisolone, means steroids has to be given for this patient. So this is what multiple sclerosis patients that we are going to see. Next condition that you have to remember is moving on to the this condition. So what is this condition? Classical case, if you can observe. So this patient is suffering from the ascending. I will give the patient symptoms. The patient is ascending paralysis. So when he admitted, he has a respiratory distress, and he also history of the infection like diarrhea. History of the infection is present in this patient, and patient bladder and the bowel is not yet involved. So this is not yet involved. So what is this condition? So obvious, this patient is suffering from the GBS, Guillain-Barré syndrome. This is due to Guillain-Barré syndrome. So this is an acute severe autoimmune attack. Okay, autoimmune attack that is caused by the patients of the GBS with ascending paralysis, involvement of the respiratory muscles, respiratory distress, and associated with the infections. What are the infection? That is a Campylobacter jejuni. It could be Salmonella. Okay, even it could be COVID-19. All these are involved in these conditions. Next, influenza vaccine. Okay, activated influenza virus vaccine can also cause this condition. We have types. There are many types that you have to remember. In India, this is going to be the most common type, that is AIDP, and this is going to contains of AIDP. The antibodies which is attacking here is the anti-GM1. Anti-GM1. We also have the Aman type. Aman means motor. This motor which will be consisting of the anti-GD1. And we also have the AMSAN. Okay, motor and sensory. This is going to also have the anti-GD1. Okay, very rare condition. That is a Miller-Fisher syndrome. Miller-Fisher syndrome. This is a very rare and this is very severe. And here it consisting of the anti-GQ1. Okay, and the criteria for the diagnosis is a Britton's criteria. Just name is important, that is a Britton's criteria, and treatment is always IV, IG, and also you can do the plasma exchange for this patient. Plasma exchange for this patient. That is what the condition of the GBS. Next, moving on to the another condition. So here you can see this patient is having very different kind of the facial appearances is seen. So these facial appearances is known as a hatchet faces. This faces is known as a hatchet faces. So where this hatchet faces is seen. So this is seen in the myotonic dystrophy or myotonic dystrophia. This is autosomal dominant condition where you're going to have the multiple repeats CTG trinucleotides are repeated in this patient. Right, that is one of the symptoms. Patient will be having the myotonia and sarcopenia, muscle weakness and wasting, and the cataract that is known as a Christmas cataract. Okay, diabetes mellitus can be seen in this patient and also hypertension. Investigation of the choice is the genetic electromyography can be also done for this patient treatment. This is an genetic condition. We don't treat much problem, just give the supportive therapy and you can minimize the complications of this patient. Next condition. So what is this sign, guys? This question is asked previously like 4 to 5 years ago. What is this sign? This sign is known as a Gower sign. So when you ask the patient, okay, the patient is sitting down, you ask the patient to get up. So most of us, we don't take the help, but this patient will be taking different types of the position to just stand up. That is what Gower sign is positive, where you are going to see. This is seen in the Duchenne muscular dystrophy. Duchenne muscular dystrophy. And they are two types. This is divided as a DMD, Duchenne muscular dystrophy, and also BMD, okay, Becker muscular dystrophy. And here the structural protein, that is dystrophin, is deficient. It is deficient. Significant levels. Here also it is deficient. Comparing to the DMD, it is just a little bit only, that is decreased in this patient. That's why it is a severe condition. It will involve the cardiomyopathy and it is a less severe or we can say mild condition, and cardiomyopathy is not seen. Even if it is seen, it will be more than 40 years. But this patient is just by 25 years only. He will be living just for 25 years. That is what Duchenne muscular dystrophy between the Becker muscular dystrophy. Investigation of the choice, we can go for the muscle biopsy, but not all the patients will be taking of the muscle biopsy. This is only sensitive part. This is mostly sensitive part, and CKMM levels, that is highly raised in this patients. And treatment of the choice is IVIG, or we can go for the steroids for this patient. So this is what the condition of the Duchenne muscular dystrophy that we have looked at. Next, moving on to the another condition. What is this condition, guys? This condition is known as a Charcot Marie tooth disease. This is a Charcot Marie tooth disease, autosomal dominant condition on the chromosome 17 that is presented, and there is a defect of the PM22 female gene. Okay, this is also involved in this patient. What are the symptoms that you are going to see? So here you can see pes cavus, that is seen in this patient. Sensory neural loss will be seen. Distal muscle wasting, here you can see distal muscle wasting is seen. Sensory neuropathy and motor neuropathy all will be combined in the Charcot Marie tooth disease. Next, moving on to the some of the miscellaneous topics, that is a very important topics. Let's say this is question has been asking previously also. Brain biopsy conditions. Okay, brain biopsy conditions that we are going to differentiate here. So most of the patients, whoever is suffering from these conditions, is associated with these type of conditions. Let's see. The first one that we are going to discuss is the Parkinsonism or Parkinson's condition. Parkinson's condition is most commonly more than 60 years of the individual, and completely the dopamine in the body is depleted. Okay, dopamine in the body is depleted. It is also a type of degenerative condition, but this is a over the time of the aging that we had, but it is also seen in the young children's, especially the chromosome 4 and the chromosome 6. So this chromosome norm is known as a PARC1 and this is known as a PARC2. PARC1 is autosomal dominant, this is autosomal recessive, but the PARC1 is more severe than the PARC2 condition. Okay, that is the one point that you have to remember. And apart from that, what are the symptoms the patient will be having? Tremors. Okay, tremors will be resting tremors, pill rolling tremors. It's not an intentional tremors. This is a uh, immediately abruptly the patient is having when the patient is in the resting. And also you are going to see the lead pipe rigidity, sudden study rigidity is seen in this patient, and also gait abnormalities. Gait abnormalities that is also seen in this patient. On the histopathology, you are going to see these kind of alpha synuclein. This is the alpha synuclein that is presented, and this is also one of the other type of the alpha synuclein, and this is the ubiquitin. This is also one of the picture that you are going to see in the myasthenia, sorry, Parkinson's condition. Next condition, we will be discussing of the Alzheimer's. Alzheimer's is a asked question, NEET PG, INACT, and also Fmge exam also this question is asked. So what are the symptoms these patients will be having? Most commonly these patients will be having the memory loss. Okay, this is a very early type of the memory loss. So the patient will be having the dementia. Why this dementia? Because decreased acetylcholine. Because of the youngsters most using the acetylcholine. So I'm just kidding. So the acetylcholine is absent in this patient. Next, it could be due to amyloid. It could be due to amyloid, due to beta amyloid in the brain, beta amyloid in the brain, and neurofibromatous condition, ApoE4 condition. ApoE4 mutation is seen in this patient, and also Down syndrome. Early stage of is Down syndrome that you are going to see. That is what's seen in this patients. And treatment. So the treatment that is given is the donepezol. Donepezol, memantine. Memantine is a question that is asked. This is the NMDA antagonist. Memantine, donepezil is given for this patient. Rivastigmine also can be given for this patient. And on the histopathology, you're going to see this. This is the amyloid, and these are the tau proteins. Amyloid proteins and the tau proteins that you are going to see in the significantly in the patients of this condition. Next. So this is a patient who is suffering from the Huntington chorea. So what is this Huntington's chorea? This is also a trinucleotide repeats. This is the trinucleotide repeats. The patient is involved autosomal dominant condition, chromosome 4 mutation. Patient is having the gait abnormalities, dementia. Dementia is seen in this patient. Chorea-like movements is seen. The name itself tells it is a chorea-like movements is seen in this patient. The treatment of the patient is supportive. Baclofen and trazodone that can be given for this patient. Okay, trazodone is given for this patient. On the MRI or the CT scan, you are going to see the features such as atrophy of the caudate, and also ventriculomegaly that is seen, and decreased glycine and decreased GABA are seen in the patients of the Huntington's chorea. And what is the trinucleotide repeat that is seen here? CAG that is seen in these patients. Next, moving on to the anemias. So in the anemias, you have to take note, as we discussed before, what are the three types. Either it could be macrocytic, normocytic or the macrocytic types of we are going to see. In the microcytic, we have the hemoglobin that is affected. It could be thalassemia, anemia chronic iron deficiency anemia, and the lead poisoning. And macrocytic is most of the times is megaloblastic, folate deficiency, B12 deficiency, and also Fanconi anemia. And normocytic is associated with the iron deficiency anemia in the early stages, anemia chronic disease, aplastic anemia, and acute blood loss patients that you are going to present with the anemia types. And hemolysis, it could be extrinsic or it could be intrinsic. In the intrinsic, this is the spirocytosis, nocturnal hematuria, and also G6PD, sickle cell anemia, HPC disease. And extrinsic is most of the time microangiopathic, macroangiopathic that will be seen in the patients of the extrinsic types. Next, we will be discussing of identification of the different cells that you are going to do. So this cell which will be presented with the spikes, okay, this is known as a acanthocytes. These are the acanthocytes. Where you are going to see in the acanthocytes, this is seen in the liver cells, okay, liver disease patients. Next, this is the echinocyte. These are the echinocytes, end stage renal disease you are going to see, and also liver disease patients that you are going to see. Teardrop. This is like a teardrop. This teardrop is seen in the patients, we can say myelofibrosis, also known as a teardrop, and also which will be called as dacrocytes. Okay, this is known as a dacrocytes. Next, helmet shape, okay, or we can say cystocytes. Cystocytes, DIC patients, most of the times hemolytic anemias, all autoimmune hemolytic anemia, all the autoimmune related conditions, and pregnancy patients, HELP syndrome. Bite cells, these are the bite cells, G6PD patients, and these are the sickle cell anemia patients. These are the target type seen in the thalassemia. This is the spirocytes. These are the spirocytes that you are going to see in the patients of the spirocytes. Okay, this is also another spirocytes seen in the hereditary spirocytosis patients. Next, this is the elliptocytosis. In the elliptocytes, the most common is the spectrin, and here the most common is the ankyrin. So these are the pictures that you have to take note and remember. Next, moving on to the endocrine. In the endocrine, we have the different types of the glands, right? We have the different types of the gland. For example, if I differentiate, this is the pituitary, and this is how we are going to have anterior pituitary, posterior pituitary. Posterior pituitary production is not there. There is nothing production. It is only for the storage. It is only for the storage. And you have the artery, so that is coming and connecting like this. Okay, this is the superior type, and this is the inferior type, hypophyseal artery. Superior hypophyseal artery. So where it is coming from? It is coming from the hypothalamus, so that the signals will reach this pituitaries to produce the hormones, right? We have many hormones in the body. Difference of the glands, difference of the hormones that will be produced in the patients. For example, let's take the anterior pituitary is going to produce the ACTH, cortisol, aldosterone. All this will be implemented. Next, uh, this is the anterior pituitary, and also TSH, growth hormone, and we also have the gonadotropin releasing hormones. In the posterior, there is no hormone, as I said, but we also have here oxytocin to store ADH, and you can also remember here prolactin. Prolactin is also produced in these patients. Why the patient is having the injury to the pituitary? For example, the pituitary hormones is look like this. So this is the, let's say, structure. So in this, most of the hormones which will be secreting here, here and here. So this area. So on the peripherals we have the these hormones. So when there is a vascular connection, okay, when there is a vascular connection is disturbed, so this will go into the necrosis. This will go into the necrosis. So that is why the patient will be having this necrosis type of the conditions with the patients of all the hormones will be decreased in these patients. Next, one by one we will be discussing. First we will be discussing of the prolactinoma. Okay, prolactinoma first we are going to discuss. So the patient here is suffering from the prolactinoma. So what is this prolactinoma, guys? Okay, high levels of the prolactin is secreting here. How can we know whether this is the high levels or the normal levels? So generally in the patients, in the normal individuals, it is normal to have 20. If the patient is having a more than 40, it could be likely to be the patient is pregnancy. Okay, and if it is more than 100, then we have to consider this could be due to the adenoma or drug related conditions. If it is more than 200, it is definitely the patient is suffering from the malignancy of this condition. Malignancy of the condition. Generally prolactin is going to always in the negative stage only during the important times it is going to increase. When? Why it is like that? Because there is known as a dopamine always keep the prolactin in the control. If the dopamine is absent, obviously the prolactin will be increased. And other than that, TRH, okay, and also during the lactation, oxytocin, this will be also increasing of the prolactin. But if the prolactin is produced more, it is going to inhibit the GnRH. Okay, it will block the GnRH. If GnRH is blocked, TSH, LSH, FSH is decreased. So that is what the whole prolactin that you have to understand. What are the causes? The most common cause for this patient is the adenoma. Okay, pituitary adenoma. Pituitary adenoma is caused, or else drugs. What are the drugs? All the antipsychotics that you can recall, haloperidol, risperidone, all these drugs can be caused. And one of the most common drug, the metoclopramide, this drug can also cause these patients. And trauma, ischemia, and also men1 syndromes, this also going to cause these patients. So how the patient is presented? Most of the time the patient will be presented with a galactoria, followed by the low libido levels are decreased, menstrual changes. As I said, the GnRH is not working in these patients, and sometimes visual field defects will be seen. Why visual field defects? Let's see. So here your optic chiasm, if this tumor is compressing, so you are going to have the visual field defects. That is how the patient will be presented. And what is the investigation of the choice? Okay, so how you are going to do investigation of the choice for this patient? So whenever the patient is presented, you have to go for the screening test. With that symptoms, you can go for the screening test. Screening test is visual field defects you have to check. If ever it is positive, patient is having severe visual field defects, then you can go for the MRI brain cut. Okay, MRI brain pituitary cut, that you can go for this patient. And how the treatment is given? So treatment is given depends on the microadenoma less than 1 mm or the macroadenoma more than 1 mm. So if it is a micro, you can go for the drugs. Even if it is a macro also, you can go for the drugs at least 4 weeks. Okay, when you are going to do the surgery. So surgery is done only if the patient visual field defects is severe, patient drug therapy is failed. So patient drug therapy is failed, right? These conditions that we are going to give the patient. And what are the drugs that we are going to give? Cabergoline. Cabergoline. It is a D2 blocker. And also bromocriptine. Bromocriptine. This is also D2 blocker, not direct D2 blocker, but it works as the same mechanism only. So the best drug, the drug of the choice is the cabergoline. that we are going to give for this patient. Next, another condition that we are going to discuss here, this is known as acromegaly. This condition is known as a acromegaly. And what is the most common cause for the acromegaly? Same, pituitary adenoma is the most common cause. Most of the times the patient is unable to express, so they just stay in their home only due to this all these features of the patient. So that is what acromegaly patients might be suffering from. One of the example is Great Kali in India. And growth hormone, whenever it is increased overly, it is going to produce the IGF levels in the liver. IGF level is in the liver. So what does this IGF will do? Okay, what does this IGF will do? So IGF is having the triad. Okay, it is going to cause the diabetes mellitus, it going to cause the hypertension, and also it can cause the organomegaly. Organomegaly. So that is what the patients with the IGF levels that is involved of this patient. So features, if you see, enlargement of the hands, parotid hypertrophy, thickening of the lips, nasolabial sulcus thickened, and enlargement of the base and burrow furrow that will be increased. So these patients sometimes cranial nerve palsy will be seen because of the compression, and patients will be also having the difficulty, the patients like air hunger or the airway symptoms will be seen because of the complete the body is more weighted, higher risk of the producing the colon polyps. It can be progressive to the patients with the malignancy also. All this will be seen. So screening test, what is the screening test that you are going to do? So for the patient of this one, you are going to check for the IGF levels, IGF levels in the body. But best investigation of the choice is the OGTT. Okay, OGTT that you are going to check for this patient. Treatment. What is the treatment that you are going to give for this patient? Octreotide. Octreotide is the drug of the choice for this patient, and also pegzisomant. Pegzisomant. This is an antagonist. Pegzisomant antagonist is given for this patient. So this is what acromegaly. Next, some of the miscellaneous conditions. What is known as a pituitary apoplexy? Okay, what is a pituitary apoplexy? So patient who is suffering from the pituitary apoplexy, remember apoplexy is a sudden damage that is happened. So sudden hemorrhage inside the pituitary, inside the pituitary. So this is known as a pituitary apoplexy or the emergency in this patient. Symptoms, sudden headache. Okay, it is like a sudden headache in the patients, and visual field defects. Okay, loss of consciousness. All these sudden symptoms will be seen in these patients. Treatment, after the recovery from the patients, making the stabilization of the patient, you can give the hormonal therapy. Next, Sheehan syndrome. What is the Sheehan syndrome? So Sheehan syndrome is a symptoms that is due to necrosis of the pituitary. Necrosis of the pituitary. The most common cause is PPH, the postpartum hemorrhage that is caused in this patient, and all the hormones, okay, all the hormones is decreased in the patients of the Sheehan syndrome. Next, we also have the stalk effect. Stalk effect means, for example, this is the anterior pituitary, this is the posterior pituitary, so this is known as a stalk. So if this stalk is compressed, most commonly due to the tumor swelling, if it is swelled, what happens? It is going to damage all the hormones. So every hormone, hypopituitarism is going to see. But here is a catch that you have to remember. Hyperprolactin. Okay, hyperprolactin. Because prolactin is always silent, it is waiting for the chance. All the hormones is decreased, but the prolactin is increased. So that is what stalk effect that you are going to see in this patient. Next, moving on to the ADH hormones. ADH hormones is having the two conditions, guys. These two conditions is highly asked in the examination. Let's see, the first condition that you are going to discuss is the diabetes insipidus. Okay, the patient is diabetes insipidus. So what is the first thing that you have to remember? Just remember this picture. The patient is so thin, the patient is standing in the urine. That means he cannot even think how much urine he is going on. So the patient metabolism, the patient activity level, everything will be decreased, and patient is depleting all the fluid from the body. So that is what diabetes insipidus. So first thing you have to understand, we have the ADH. This is known as a vasopressin. Okay, we have V1, V2 and V3. So V1, which we consist of the vessels. V2, remember this is present in the kidneys, collecting tubules. V3 is known as a von Willebrand factor that is present. It's okay. Okay, sorry, this is the von Willebrand factor that is present here. And V3, this is present is due to IP3. Again, this is present in the vessels. So this is how all the V1, V2, V3 which will be presented. So V2 that is present in the kidney. What is the role of the kidney? So kidney will do the water retention. So more and water has to be absorbed back from into our body. So that is what the function. So here the ADH is not working. So water cannot be reabsorbed. So water has to be go out. So that is what happening here. So we have two types. One is the central diabetes insipidus, and we also have the nephrogenic related insipidus, diabetes insipidus. So this, let's see the condition. So patients who is suffering from the diabetes insipidus, central diabetes insipidus, the defect is in the pituitary itself. So ADH is absent. Here ADH is present, but the defect is in the kidneys. Okay. For example, V2 is not working or aquaporin channels is not working. Here kidney is perfect. Here kidney is normal. So this is the difference between the nephrogenic and the central DA. And what happens here? The patient will be having polyuria, polydipsia. More and more fluid is losing in the body, and urine osmolarity is increased. Next, coming to the kidneys, same as kidneys also, patient can have polyuria, polydipsia. Okay, urine osmolarity, again it is increased in these patients. That is what we are going to see. What is the drug of the choice that we can give for this patient? For this patient, the ADH itself absent, we can give the desmopressin. Here the defect is kidneys, we can give the activation of them. Drug of the choice for this patient is the thiazides, which can be worked back. Okay, thiazides can be given for these patients. And what is the investigation of the choice for this patient? Water deprivation test for both. This is the water deprivation test. And what is the most common cause? Due to tumor, paraneoplastic tumors. Paraneoplastic tumors related to the lung pathology. That is what we are going to see in this patients. Next, another condition is opposite to that. SIADH means increasing the SIADH. ADH has to do one function, that is water retention. If the SIADH is acting more and more, so the fluid will be inside only. Complete, it is going to take it back into the inside only. So that is what we are going to see in this patient. And SIADH most commonly seen, again same lung cancer, paraneoplastic syndromes. It is also seen in the paraneoplastic syndromes of the lung cancers of the patients. Next, how it is going to present it. So the more and more SIADH will be seen in these patients. So the water is retaining and retaining. Water retaining and retain. More water, more sodium inside the body. So the patient will be having the more water, more sodium that will be inside. So high cardiac output, high BP will be increased in these patients. That is what. And urine. Coming to the urine, urine is more concentrated. Urine is more concentrated, so that urine osmolarity which will be decreasing here these patients. And when the BP is increased, it is going to activate in the heart natriuresis. Okay, natriuresis. This natriuresis will cause the euvolemia plus hypernatremia. Okay, euvolemia and the hypernatremia. So here we have the hypervolemia plus hypernatremia. but here it is euvolemia because of the natriuresis that is happened in our body. And this is how we are going to maintain the SIADH for this patient. And here the test that we can do for this patient is the water deprivation test. Sorry, water deprivation test is already done. So here we are going to do the water loading test. Water loading test is done for this patient. Drug of the choice is the Vapton. Vapton is V2 blocker. In the kidney, it is going to block the V2, and water loading test can be done for this patients. So this is how we are going to differentiate between the SIADH and the diabetes insipidus condition and some of the miscellaneous conditions. Next, moving on to these conditions that you have to remember: adrenal gland. Where is the adrenal gland is came from? Adrenal gland is came from the mesoderm. Adrenal medulla is came from the neuroectoderm. Sorry, neural crest. This is came from the neural crest. So this is from the mesoderm. We have the three layers: zona glomerulosa, which produce the aldosterone; fasciculata, cortisol, reticularis, testosterone, and the estrogen. And this is present by birth, same as this is also present by birth, but this is going to develop at the 3 years of the age. This is not developed by birth, it is actually came from the by age. Next, we will see the medullary pathology. So first we will be having the medulla, and this medulla is going to produce the two hormones. What are those hormones? Epinephrine, okay, and norepinephrine. So if the epinephrine is 80%, norepinephrine is just 20% that we are going to produce in our body. So if ever the medulla can develop the tumors, so these tumors is going to produce the chromaffin cells. Okay, this produce the chromaffin cells, and the tumor that is related to the chromaffin cells, that is known as a pheochromocytoma. Chromaffin cells. This is what the medullary cancer that is going to develop. So when this medullary cell is the medulla cells is developing, most common cause is adenoma itself. Within the medulla there is an adenoma, or patient is suffering from the MEN syndromes, MEN 1, MEN 2, MEN 3. These symptoms will be seen in these patients, and this is also secondary to the ectopic tissues. Okay, again, paraneoplastic syndromes or paragangliomas. But this is going to follow the one of the best rules that you can remember: 10% rules. 10% of the patients it is associated with the bilateral. 10% of the patients it can be malignant lesions. Okay, 10% only the population that is involved in this patient, and in that females is more common than the males, and 10% is extraadrenal. 10% is the extraadrenal, and only 10% can develop the metastasis of the condition. How the patient will be presented? Most of the time patient will be having the headache, which is ignored by the patient, or patient is having the hypertension, patient is having the palpitations, okay, palpitations and sweating. All this will be presented recurrent attacks. Okay, this will be recurrent attacks that you are going to see, and the hypertension is most of the times resistance, it is not decreased. And investigation of the choice for these patients, you have to check the metanephrine levels. Okay, metanephrine levels in the 24 hours of the urine assay, so that you can confirm. But the best is the serum. Best is the serum metanephrine levels. How we are going to treat these patients? So the treatment for this patient, I am going to use the ABC rule. So what is this ABC rule? First, admit the patient and start the patient on the alpha blockers. Start the patients on the alpha blockers. B for beta blockers and C for cure. How you are going to do? How you are going to cure? Surgery. Remove the tumor mass. Alpha blockers and CCB is given for the 7 days before the surgery, and 3 days before the surgery beta blockers, and on the day surgery you can use the sodium nitroprusside you can use for these patients, right? This is how we are going to treat the patients of these conditions A, B, C. Next, moving on to the another condition, that is hyperaldosteronism. Okay, this is the adrenal mass that you are seeing here. So we have the hyperaldosteronism. So what is mean by the hyperaldosteronism? So nothing but the aldosterone is raised in these patients. One among them we can discuss is the hyperplasia, bilateral hyperplasia. This is the most common overall, and unilateral adenoma. Unilateral adenoma is also known as your famous Fmge favorite Cons syndrome. Okay, so this is the pattern, but symptoms are both will be having same. So we will be discussing of the Cons syndrome. All the following is same, except then you should not miss this Cons syndrome patients. So Cons syndrome patients, whenever this is increased, it is going to increase the aldosterone. Okay, it is going to increase the aldosterone. What does the aldosterone will do? Aldosterone will increase the sodium, decrease the potassium because it is excreting out, and decrease the H plus ions, and also this is going to increase the more and more water retention, right? This is the aldosterone function. So obviously the patient is having the hypertension, that is the first thing, and patient will be having the increased sodium and decreased potassium, hypokalemia and hypernatremia, and metabolic alkalosis is seen in this patient. So metabolic alkalosis is seen. So first investigation of the choice for this patient is the saline infusion test. Saline infusion test and renin test. Okay, renin is decreased, then it is seen with the Liddle syndrome. Okay, Liddle syndrome you are going to see. Treatment for this patient is the spironolactone. Spironolactone. So this is what hyperaldosterone patient. Next, moving on to the another adrenal condition, that is completely shutdown of the adrenal gland. So this is the complete shutdown of adrenal gland, also known as a Addison's disease. This is known as a Addison's disease. Most commonly, Addison's disease is an exogenous condition. This is the most common. Apart from that, in India, it is associated with the TB and patients with the HIV condition. So this is associated with the TB and HIV conditions of our world. In the India, most commonly, this is due to TB. Next, what does the Addison's disease is doing? Addison's disease is doing adrenal shutdown. Let's take this as a shutdown. So the patient is unable to produce the cortisol. Patient can unable to produce the aldosterone. Patient cannot produce the sex steroids. So just recall the symptoms. What are they associated? Cortisol is decreased. So the patient glucose is decreased because it is a counter regulatory hormone. So aldosterone is decreased. The patient can have the hypotension, and the sodium is decreased in this patient, and potassium is increased, right? This is what we are going to see. And metabolic acidosis. Sex steroids are destroyed, so the patient is having the infertility, or the patient will be having the libido issues, menses problem. All this will be seen in this patient, right? So this is what associated with the Addison's disease in this patients. So investigation of this choice is the ACTH stimulation test. This is the AC stimulation test. Treatment, we can go for the IV or IM hydrocortisone. Hydrocortisone is given for this patient. We also have the adrenal crisis. When the adrenal gland is ruptured, this is going to cause the fever, syncope, convulsion, hypoglycemia, hyponatremia, severe vomiting and diarrhea, and this is associated with the Neisseria species. Adrenal hemorrhage can be seen with the Neisseria species. Next, last but not the least, that is known as a Cushing syndrome. So this is a patient who is suffering from the Cushing syndrome. Cushing syndrome has the different types of the conditions. In India, most misused, that is the steroids. So most common cause iatrogenic external or the over the counter taking of the drugs with the steroids. Next, who is adult? If you see adult patient, then this is due to pituitary adenoma. Pituitary adenoma. If you see infant, this is due to McCune's Bright syndrome. McCune's Bright syndrome. If it is a children, it is the adrenal hyperplasia. It is adrenal hyperplasia. These are the causes. Investigation of the choice, you have to do the dexamethasone suppression test, suppression test, and on the dexamethasone suppression test you have to check for the levels. If the levels is decreased, so then it is a negative. If the levels is increased, then it is a positive. So after that you have to go for the MRI. After that you can go for the MRI, and depends on, you can go for the treatment. And the drugs that we use for here is the ketoconazole, okay, epinephrine. These are the drugs that we can use for this patient. Next, Cushing syndrome, having the symptoms of mood disorders, weakness and the fatigue, thinning and loss of the hair, round swollen head, face which is known as a moon faces, redness in the cheeks, amenorrhea, skin ulcers, muscle loss, easy bruising, abdominal stress, and osteoporosis. One point that you have to add here, what is the test that we are doing here? ACTH. Okay, we are doing the ACTH. In the recent INICT also this question is asked. So this is what the Cushing syndrome. Right, completed. We have completed the most of the adrenal and important other topics also we have completed. Next, moving on to the parathyroid hormone, and also related to the calcium metabolism. So there you can see, so the patient is having the pituitary hormone, that is backside of the thyroid, four glands is presented. These are the four glands that we have. And how it is going to act: whenever your body tells that the calcium is low, so immediately the pituitary is going to activate it. It is going to bones, intestine, and also to the kidneys. In the kidneys, it will tell to reabsorb the calcium more and excrete the potassium. Send the potassium out, phosphorus, send the phosphorus outside and bring the calcium inside. And osteoclastic in activity is increased. Here the calcium is increased, and calcium absorption. All this will going to increase the calcium. That is what the parathyroid hormone will be doing us. Next, coming to how it is going to be presented. So it could be presented as a primary hyperparathyroidism. Primary hyperparathyroidism. Most common cause is the adenoma. How you are going to check? You are just going to check how the patient is presented. If the parathyroid hormone is increased, obviously the calcium will be increased. So parathyroid hormone is increased, increased calcium. Phosphorus has to go out, so the phosphorus will be going out. But the osteoclast is elevated, so ALP is also elevated in this patients, and the patient will be having increased calcium, pain, gones, and stones. All this will be seen in these patients. Next, we also have the secondary hyperthyroidism. Secondary hyperparathyroidism. Secondary hyperparathyroidism is most commonly due to CKD. So the patients who is suffering from the CKD. So he is a false positive. So parathyroid hormone is actually decreased. Calcium is decreased, and CKD, it cannot send the phosphate out. So the phosphate is going to build inside the body. So that is what we are going to see, the primary parathyroidism and the secondary parathyroidism. We also have the pseudo hypoparathyroidism. So in this you don't have to remember anything, but the gene that is involved is the NANS gene that is involved in this patient. Pseudo hypoparathyroidism the patient is suffering from. Next, the recent INICT questions. If ever you see that the patient is having the hypercalciuric crisis, how we are going to treat this patient? First and foremost, you have to start the patients with the IV fluids. Okay, then you have to give the thiazides for this patient. Can we give the thiazides? No. Thiazides can increase the calcium. So thiazides is contraindicated. As such as any drugs that is present in the patient with the drugs that is increasing the calcium, you have to remove those drugs. First start the IV fluids, remove the drugs, then start the patient on the bisphosphonates. Okay, start the patients on the bisphosphonates drug therapy that has to be started for this patient. So this has to be started and that has to be stopped. So this is how you are going to treat the hypercalciuric crisis in the patients. Next, moving on to the thyroid synthesis. We are going to looking at here thyroid synthesis. First, the thyroid is actually has to be produced from the thyroid gland only, but we have the some of the triggering factors. What are those triggering factors? We have to take the iodine from our diet. We have to get the iodine, and these iodine which will be entering of the follicular cell, okay, with the help of the sodium and the iodate symport. So after that it is entering, it is going to enter the colloid. So where the most of the hormone will be produced. So this iodine is going to convert as the iodide, which is known with the help of the peroxidase enzyme. This is known as a iodination. This is known as a iodination. Once it is produced as iodination, it is going to bind with the thyroglobulin, which forms the monoiodothyronine and also diiodothyronine it is going to produce. So this T3, T4 is produced inside the colloid, and once they get the time, they are going to convert and come back to the T4 and the T3. So this is how the thyroid metabolism which will be going to see in this patients. Next, coming back to the thyroid gland and how these patients will be presented. So first and foremost, thyroid is not just produced by the thyroid gland itself. So first we have to get the triggering factor from the hypothalamus. This will tell the pituitary gland produce the TSH, and this will tell us the T3 and the T4 to produce. For example, if I got the normal levels, then I will tell the TSH please stop, and TSH will tell the TRH please stop. So this is how the negative feedback mechanism and the positive feedback mechanism of the thyroid gland is working. But then how we are going to differentiate, how we are going to characterize these patients. So for example, let's see, the patient is suffering from the primary hypothyroid. So in these patients, let's see T3, T4 and TSH levels. What about the secondary hypothyroidism? Subclinical, hypo, primary hyper, secondary hyper, and also again subclinical hyper. How we are going to differentiate these patients? Let's see one by one. So primary hypothyroidism patients, that the T3 and T4 is decreased. So the gland that is not producing these hormones. So if it is not producing, negative feedback mechanism TSH will be increased. But over the time, the gland will be understanding, okay, the thyroid is having the deficient. So everything will be decreased here. Same as a hyperparathyroidism also. Hyper means producing more and more. So if it is producing more and more, it will tell the negative feedback mechanism to produce that TSH less. So TSH is less. And after the time, all the levels will be increased. So that is what's seen in the secondary hyperthyroidism. But in the patients of the sub hyperthyroidism, the patient will be having decreased levels, but this is going to be normal levels. Okay, like a picture here, negative feedback mechanism. Subclinical also, these are going to be normal, but it is going to raise. That is what the subclinical hypothyroidism, with the help of this laboratory findings, you can get to know. Next, see the symptoms of the hypothyroidism or the hyperthyroidism. Hypothyroidism, there is a basal metabolic rate that is decreased. So here the basal metabolic rate is increased in this patient. So loss of eyebrow, thinning of the hair, puffy face, enlarged thyroid, that is goiter, slow heart rate, poor appetite, constipation, dry hair, and alopecia, cool extremities, carpal tunnel syndrome, heavy menstrual bleeding. All this will be seen in the patients of the hypothyroidism. So this is a hypothyroid condition. What are the possibilities? Hashimoto. Hashimoto is the most common type, where you are going to see the Hurthle cells, and the antibodies that is involved is the TPO antibodies, thyroid peroxidase enzyme, and the thyroglobulin antibodies that you are going to see. Another one, we have the Reddy type. Reddy type, this is known as a fibrosis. Okay, hard gland that you can feel, gland is destroyed. Or we have the decurrence. Decurrence, this is a painful gland swelling due to viral infection. These are the hypothyroidism causes. Next, hyperthyroidism. You can see bulging eyes, that is known as a ophthalmopathy, enlarged thyroid, goiter, heart rate is increased, increased appetite, loss of libido, nausea, vomiting, tremors, and enlarged liver, perspiration, heatness of the body. All this will be seen in the patients of the hyperthyroidism. So hyperthyroidism patients, the most common condition is Graves' disease. So this is a Graves' disease, and this involved iodine receptor, TSH receptors. These are the antibodies that is destroyed by the Graves' disease. And this picture is known as a Brown's tumor. This is known as a brown tumor seen with the primary parathyroid increased levels. That is a primary increase that is level. That is with the brown tumor that you are going to see. So these are the some of the important conditions that you have to take note of the thyroid diseases. Next, moving on to the hepatology. We will be discussing very glimpse that is small appear very in short that you have to take note about the hepatology. First is hepatic serology. How we are going to differentiate between the hepatitis serology. For that, you have to take note what are the viruses that is present. We have the HIV, okay, HAV, we have HAV, HBV, HCV, HDV, HEV, right? These are the presentations. Next, what are the viruses that we have? What are the viruses that is containing here? So this is a ssRNA, this is dsDNA, and remaining all also ssRNA. Okay, all are going to be the ssRNA. Next, which of the following is naked? These two are naked, and remaining all are enveloped. Remaining all are enveloped. Incubation period less than 50 days, 180 days. This is going to be 180 days. HCV is also 180 days, and also we have here this is a 60 days, and this is 30 days. 30 days. Next, how the route of cause? Feco oral, feco oral. It could be STD, it could be injections, or it could be vertical transmission. These three will be having this STD, injections, or the vertical transmission from mother that can be seen. And which of the following is associated with the hepatocellular carcinoma? Again, B, C, D. And here it is not seen with the hepatocellular carcinoma. Cirrhosis, patient can develop the fibrosis. This is also seen with the B, C, D, but not with the E and V. E and A that you are going to see. So chronicity and the carcinoma is seen with the B, C, D. That is the first thing that you can remember. Next, most common overall in India. What is the most common overall in India? Right now, India is suffering from the HEB, and most commonly this is associated with the pregnancy people, and in the pregnancy people this is associated with the severity. High severity cases can be seen. Next, co-infection. Co-infection is seen with the B plus D. Co-infection is seen with the B plus D. If you see IgG, this is the superinfection. IgG, this is the superinfection. But if you see IgM, this is the co-infection. This is a co-infection, and we are going to check the hepatitis B serology, right? Using this graph that you have to don't forget. First, we are developing the antigens. Okay, this antigen is lifetime. It is going to be having. Next, antigen, other antigen that is a HBe antigen, and over the time it can develop the after curation it is the anti-HBe antibodies will be developed, and anti-HBc antibodies and the IgM HBc antibodies also produced. So let's see one by one how we are going to understand this. First, let's say we develop the antigens. We develop the antigens. What are the antigens that we developed so far? First antigen to produce is the HBsAg. This will tell us whether we infected or not. Second antigen is produced is the HBeAg. Okay, this will tell us it is an active and it is an infective and it is highly replicative. All this will be understood by the HBeAg. Right? Next, we produce the antibodies. Anti-HBc antibodies. This will be associated with the IgM or the IgG. IgM is the acute, you all know. IgG is the chronic, right? Next, anti-HBe. Anti-HBe. This is the inactive, so that means the infection is less, same as the replicity is less. Next, anti-HB Yes, antibodies. So this is present in my body, this is present in everyone's body if they are vaccinated. This is for the vaccinated or completely cured from the disease. Okay. Next, treatment of the choice, we are going to give the tenofovir for the hepatitis B virus. Sodosofir, this is given for the HCV. Recent INICT question also asked on this sodosovir and the tenofovir. Okay, these are the drugs that we are going to use, and this is how the serology that you can understand from this picture. That is the one point that I want you guys to understand. Next, moving on to the other conditions, here you can see this is a Whipple's disease. Okay, Whipple's disease. So what does the Whipple's disease will do? So Whipple disease is caused by the bacteria. So the bacteria name is a Tropherima whipplei. Tropherima whipplei is a condition, and this bacteria is going to present in the most of the 50 years individual, most commonly males. And what are the symptoms? It has a specific triad. It can cause the malabsorption, and also knee involved arthritis will be seen in this patient, and CNS, as per the age, the patient can have the dementia. Okay, so this is how the patient will be presented. But the most prominent, that is the malabsorption that will be seen in this patient. If the CNS is involved, so this is considered as a poor prognosis for the development of the patient. And on the histopathology, you are going to see this foam cells. Okay, you are going to see this foam cells. Foam cells is nothing but it is filled with the neutrophils, as it is an early stage of the patient, right? This is also pass positive patients. What is the treatment for this patient? The treatment that we can give for this patient is a ceftriaxone for 14 days. IV has to be given for these patients. Next, moving on to the another condition, that is a tropical sprue. Tropical sprue is seen in the Caribbean. So these are the locations that you are going to see. Even in the Southeast Asia and the South India, especially in the India, that you are going to see the tropical sprue. So what is happening in the patients of the tropical sprue? This is a post-infectious condition. This is a post-infectious conditions associated with the E. coli patients. This will be involving of the small intestine. This small intestine can produce the pan intestine. Okay, pan intestine. All this will be going to attack. Okay, all these are going to be attacked by the different antigens. So that is what tropical sprue. Okay, increased inflammation due to attack, and which will be causing of the villus atrophy. Villus atrophy will be seen in this patient. So there is a malabsorption, and also iron is decreased, B9, B12 can be also decreased. All the important micronutrients will be seen. So the villi atrophy or the villi flatten you are going to see. So this is how the patients will be suffering from the tropical sprue. So this is a very rare condition, and the treatment is T for tropical sprue, T for tetracycline. T for tetracycline can be given for these patients. Next, the last condition that we have to discuss, this is a celiac disease. This is a celiac disease patients. So those who are suffering from the celiac disease, it is a type of autoimmune condition. This is an autoimmune condition, IgA condition, and gluten sensitive condition. So whoever take the gluten, so this IgA autoimmunity will be increased in this patients. So that is what it is associated. And HLA association is a DQ2. HLA association is a DQ2. And test, if you do, the best sensitive test for this patient is the IgA anti-TTG antibodies has to be presented. Next, gold standard. Gold standard is the biopsy. Duodenal biopsy has to be done, and for that we use the Marsh staging. Marsh staging is used. First one, you are going to see the lymphocytes, crypts, hyperplasia, crypts are hyperplastic, and villus atrophy. Villus atrophy is seen in this patient. Next, This is a condition that is known as a dermatitis herpetiformis. Dermatitis herpetiformis seen with the celiac disease patients. How you are going to treat these patients? Just simply stop the gluten. Okay, stop the gluten, especially the barley, rye, oats, and wheats has to be stopped for this patient. So this is what the celiac disease. Next, moving on to the very short topic and but highly important topic that you have to take note. So this is the ABG analysis. Okay, that I am going to discuss the ABG analysis. Whenever I am going to do the ABG analysis, I am going to do the two tests. Okay, one is the Allen test, or we commonly doing nowadays is the modified Allen test. This is the modified Allen test that we are going to perform. So these modified Allen test, you are going to occlude the both sides of the ulnar and the radial artery and release this artery. When you release this, after 15 seconds, the perfusion is back. That means there is no abnormality in the collateral circulation. So that is what the patients with the arteries that you are going to check. So this is how we are going to check for the patients. This is the modified Allen test. You are checking for the both the ulnar and also radial, okay, for the collateral circulations. Next, ABG analysis. When we say the ABG analysis, where you are going to check? Okay, brachial artery. So the sample can be taken from the brachial artery, can be taken from the radial. In emergencies, easy access you can get from the femoral artery. Most common, okay, this is the most common in emergencies because palpation sometimes in the brachial is unable to get, that you are going to check. Okay, next, indications when you are doing this, especially in the ICU wards, okay, in the surgery, shock patients, COPD patients, okay, because of the respiratory conditions, to know how much is the distinct respiratory diseases, transfusions, okay, transfusions, trauma patients, and also those who are taking the IV fluids, drug abuse, patient who is claimed with the drug intoxications, diabetes mellitus DKA, and also hyperosmolar, hyperglycemic crisis. All these conditions, I am going to get the indication for the ABG analysis. That is the first point. Next, moving on to the ABG, how I am going to check. In my body, there is a ABG present. Okay, pH, PCO2, and the HCO3. So for that, I am going to put the numbers. pH in my body is 7.4. HCO3, it is in my body is 24. It is 24, and PCO2 in my body is 40. Let's take an average. I'm not telling these are the exact, this is average. And PO2 is more than 80 plus is present in my body. So whenever you have to see, first of all, you have to check for the primary defect. So primary defect or the primary deficit, you have to check. For example, pH is low or the pH is high. pH is low, this is concise to the acidosis. pH is high, then this is go for the alkalosis side. This is will be favoring for the alkalosis. Next, you have to check for the secondary deficit. So these secondary deficit, either PCO2 or the HCO3 that you are going to check. So this is going to differentiate us between the metabolic types, acidosis, and metabolic types of the alkalosis. Same with the respiratory also. So respiratory acidosis and the respiratory alkalosis. So let's see one by one how this is going to present it, right? So first pH and PCO2 and HCO3. So metabolic acidosis, primary defect, what is it? pH is low. So same as that, PCO2 and the HCO3 will be also decreased. Metabolic alkalosis, primary defect is pH is high, and this will also follow the same rule. So metabolic will be following same. Everything will be decreased or everything will be increased. Depends on the primary defect. Next, respiratory. Remember this is opposite. Okay, this is opposite. Respiratory opposite, that you have to remember. So respiratory acidosis, primary defect acidosis is low, then this is opposite. As I said, acidosis means HCO3 will be increased, PCO2 will be increased. Respiratory alkalosis, and alkalosis means it is pH will be high and these both will be decreased because it is a opposite as we discussed. So this is how you are going to get the basic idea how you are going to get. Okay, first thing that you have to take note, and what are the conditions that is associated. Recently, again, this is the ionicity PYQ. So metabolic acidosis conditions where you are going to see especially DKA patients, lactic acidosis patients, diarrhea. Okay, any poison conditions. Metabolic acidosis, again, anion gap I will be discussing, but just you have to take note of this examples. Metabolic alkalosis. Metabolic alkalosis, vomiting, loop diuretics are the patients who is taking the thiazides, and increased aldosterone. Increased aldosterone. Next, respiratory acidosis. Respiratory acidosis is seen with the asthma, patients with the pneumonia, or some obstruction that is going to be seen here. Next, respiratory alkalosis, commonly altitude sickness, right? Altitude sickness, and also who is having the hyperventilation, and also pregnancy. But in the pregnancy, we consider this as a normal finding, and anxiety issues. All these conditions you are going to see the respiratory alkalosis. Okay, so how we are going to check? Whenever there is a metabolic acidosis, hyperventilation, so that we will be having the respiratory compensation. Metabolic alkalosis, hypoventilation. Respiratory acidosis, the HCO3 reabsorption will be increased. Respiratory alkalosis, HCO3 reabsorption is decreased. So this is how we are going to compensate. For the metabolic, respiratory will compensate. For the respiratory, metabolic will be compensated by the renal findings. So these are the examples that you have to take note. But here comes the twist, how you are going to differentiate between the compensation. Okay, how you are going to differentiate between the compensation, because you are using the Winter's formula. So for the metabolic acidosis, it is going to be 1 milliequivalents will decrease for the 1 HCO3. So alkalosis, 1 milliequivalents will decrease for the HCO3 of the 0.7 mmHg of the PCO2 will be increased. But basically, whenever you are looking for this Winter's formula, it is highly task for you guys to calculate. You can just remember this Winter formula, but I will tell another trick also for you guys so that you can remember for the long time. Let's take the first scenario that the patient pH is decreased significantly. Patient CO2 is normal, okay, and HCO3 is decreased. So what is this condition? So this condition, primary defect. What is the primary defect? This is the acidosis, and same way it is going. So this is known as a metabolic acidosis, primary defect. Okay, next, compensation. Is the compensation is happened or not? What we discussed just now, if there is a metabolic acidosis, hyperventilation has to be started. CO2 should not be normal, CO2 has to be decreased, but here CO2 is normal. So that means this patient is uncompensated. This patient is uncompensated. Next scenario, next patient. pH is decreased, CO2 is decreased, and HCO3 is also decreased. What is this condition? Again, this is a metabolic acidosis, primary defect. What is the compensation? Compensation has to be started, hyperventilation. So CO2 has to be decreased in this patient. So CO2 is decreased here. So this is a partial compensation. That means compensation is started. Lungs is restoring it. Next, third scenario. pH is normal. pH is normal. CO2 is decreased. HCO3 is decreased. So if both is decreased, the pH, let's say pH value is 7.5. So that means pH is okay. Let's keep this as a 7.4 only on the other end. So pH is also coming to the near point only. So that means the primary defect here is the metabolic acidosis. But pH is back to normal. Primary defect is back to normal. So that means complete compensation is done. Complete compensation is done. So this is what the different types of the compensations that you can find out. So okay, so this is the best way that you can recall. And next, moving on to the features, different features and how you are going to check. First, check the pH. If the pH is less than 7.3, it could be acidic, respiratory acidosis, or the metabolic acidosis. What are the examples? Airway obstruction, chronic lung disease, weakening of the respiratory muscles, opioids and the sedatives, respiratory acidosis. Next, metabolic acidosis. We have the anion gap. How we are going to check the anion gap? Sodium minus chloride plus the high bicarbonate. If it is more anion gap, this is known as a hagma. What are the example? Glycol poisoning, L-lactic acidosis, and also aspirin, ketones, diabetic ketoacidosis, alcoholic acidosis, starvation, and the renal failure. Just remember these examples that I have marked. Next, normal anion gap, spironolactone, Addison's disease, renal tubular acidosis, diarrhea, and hypercholeremia or the hyperelimination. Next, pH is high. It could be alkalosis, metabolic alkalosis, hyperventilation, anxiety, salicylates, pulmonary embolism, pregnancy patients, metabolic alkalosis, hyperaldosteronism, Gentleman syndrome, diuretics, vomiting, and the antacids. So this is how we are going to differentiate between the different types of the examples in the examination. But please do not make this mistakes because this is a very important topic of the ABG. Next, last but not the least topic of this session, that is diabetes mellitus. In the diabetes mellitus, I want to discuss the types of. The diabetes mellitus is an antrum that is consisting of the different types of the pathologies. Okay, that is the different types of the pathologies. So whenever we have the production of the glucose, what does this glucose will be doing? The glucose will be going to send the energy to the adipocytes, to the muscle, to the brain, to the liver, and to the pancreatic islets. So glucose is a very important energy production for all these structures. First point. And the second point that you have to remember, how the glucose is activated. So the glucose once is came into our blood after the fed state, after we eating, so the glucose will be coming into our body. So this will enter the beta cell. This is the beta cell. So once it is entered the beta cell, it is going to converted as a glucose 6 phosphate and glycolysis is done. Glycolysis will produce the ATP. ATP will close the ATP sensitive sodium channels, sorry, potassium channels. Once the potassium channels is closed, so this is going to close, the potassium will be increasing inside the cell, so that will cause the depolarization. Inside there is a negativity, sorry, positivity will be increased. That is what the depolarization. Once the depolarization is activated, this calcium channels will be opening, so the calcium will come inside the cell. The calcium will act on the CAMP and produce the secretory granules. These secretory granules is nothing but the insulin, C-peptide, and amylin products. So this is how the blood circulation will be getting inside, and the insulin will take back to all these cells glucose. uh, Glucose will be reuptake into the muscle, adipocytes, brain, liver, and every structure. So this is how the glucose general metabolism will be seen in the patients. So the beta cell is very important for us. So how you are going to differentiate different types of the diabetes mellitus that we are going to see. So first and foremost, there is a type 1 diabetes mellitus. Type 1 diabetes mellitus is an autoimmune condition seen in the young individuals, especially due to infections that is going to destroy the islets, or it can destroy the beta cells. So lifetime this patient insulin is absent. The most common antibodies is anti-GAD65, that is positive for these patients, that is destroyed completely. Type 1. Next, type 2. Type 2 individuals is an acquired, or we can say this is due to genetics, and here insulin is resistant. Insulin is resistant. Even though insulin is normal, but it is resistant. It is unable to open. Okay, that is what we are going to see. Type 2 diabetes mellitus. And older individuals, more than 30s, more than 40s, the patients will be presented. Next, we have the LADA. LADA means latent associated. Okay, this is a late onset diabetes mellitus in adult. So that means it is a type of type 1 diabetes mellitus, but presented as a type 2 diabetes mellitus in the adult. So initially these patients is given oral hypoglycemics, but over the time we understand that this is also due to antibodies. So we are going to shift these patients onto the insulin. Okay, next MODY. So MODY is a type of maturity onset. Okay, this is known as a maturity onset diabetes mellitus in the young individuals. This is seen with the young individuals. Most common overall type is the MODY 3. This is the most common overall type, and the defect that here is the HNF defect. HNF defect is seen in these patients. Next, we have the different types. Type 3B, sorry, type 3A. This is due to amyloid. This is due to amyloid type. Next, type 3D is due to drug induced type of the condition. Next, we also have all these which will be seen with the gestational diabetes mellitus pregnancy people at the age of 24 weeks of gestation. They have high chances of producing. So these are the some of the points that you have to take note when you are differentiating. Next, how you are going to diagnosis based on the test. First and foremost, you are going to do the fasting plasma glucose. If it is more than 126, the diabetes mellitus is confirmed. HbA1c more than 6.5, it is confirmed. 2 hours postprandial glucose is more than 11.1 or the 200 milligrams, that is also considered as a type 2 diabetes mellitus. Only you are just checking the random blood sugar, but the symptoms is presented, then 200 plus, this is also considered as a diabetes mellitus. Sometimes pre-diabetes is also asked. 100 to 125 fasting, that is pre-diabetes. 5.7 to 6.4 HbA1c pre-diabetes. 140 to 199 of the postprandial, that is also considered as a pre-diabetes mellitus. But HbA1c is best, is the HbA1c is best. Why HbA1c is best is it is a HB glycosylated. This is a glycosylated. So this test is best to review treatment protocol. So if the treatment is working or not for this patient progression, because it will be telling us last 3 months how the glucose is elevated inside. So that is how we are going to get. But sometimes this glycosylated hemoglobin sometimes is going to give us the false positive. Okay, especially patients who are suffering from the anemia conditions, who are having the liver disease, and also hemophilias and thalassemias. All these conditions we may get the false positive conditions that we are going to see. Next, whenever you want to diagnosis type 1 between the type 2, so you have to check for the C peptide. C peptide is produced by the beta cells, right? In the blood, if the C peptide levels is raised, or in the blood if the C peptide levels is decreased. C peptide levels is increased or it is negative. So this is a type 1 diabetes mellitus. So this is a type 2 diabetes mellitus. Because beta cells is completely destroyed. So that's why C peptide is negative in this patients. So that is how we are going to differentiate in this patients. And C peptides is also increased in the insulinoma patients. That is how we can differentiate between these two types of the conditions. Next, we also have the fructosemia. This is a 3 weeks only. So this is like a 3 months, right? This will tell us a 3 weeks type of the test that we can get from this condition. Next, coming to the important points that you have to remember. For example, what are the micro and the macrovascular complications that we have? Okay, first, macro complications is the early complications. This is due to age. What is the age? All the glycosylated products is coming from the increased glucose is going to cause the macrovascular complications. For example, cerebrovascular accidents, or the patient is having the coronary artery disease. So these are the macrovascular complications. Or the microvascular complications, it could be late or it could be severe also. In the early stages also it is presented. For example, the patient is retinopathy. The patient can lose the eyes. Patient can have the nephropathy. So kidneys may shut down and the CKD can happen, and also neuropathy. Okay, so the nerve damage will be seen. So this is how the micro and the macro complications will be seen in these patients. Next, insulin. How you are going to give the insulin for these patients? We have the different types of the insulin: the rapid acting, short acting, intermediate, and the long acting, and also ultra long acting that you are going to give for these patients. So they are the different types of the names: Lispro, Aspart, Glucine. These are the rapid, and the short acting is the regular. Intermediate is the NPH, long is the determinate, and long is the glargine that we have presented. Most of the times we use the regular as a protocol. This is the short acting because sometimes the patients might be taking again and again. So to prevent the hypoglycemia, we are going to give the short acting types of the condition. But when you are going to give the insulin for the patient, okay, insulin is given for the type 1 diabetes mellitus. Okay, Nick Jonas, Priyanka Chopra husband is the type 1 diabetes mellitus. Next, patients with the MODY because of the antibodies, and the LADA, this is also antibodies, and pregnancy patients. All this has to be taken the only of the insulin that has to be taken. But in the type 2 diabetes mellitus, if it is more than 9.5%, even despite of the triple therapy, even despite of the triple therapy, the glucose levels is not decreased, then also we are going to take. And DKA complication, we can go for it. And also if the patient is developing of the macro or the microvascular complications, then also we have to go for the patient on this drugs only. So first we start with the patient individualized glycemic control. First, medical therapy, physical activity, weight loss, and the first line of the drug is the metformin. And assess the HbA1c. Combination can be added the second agent. HbA1c is reassessed. Combination of the two agents is added. If still it is not controlled, then we can go for the insulin. What is the target of this HbA1c? Always it should be less than 7%. That is the target that we have to maintain whenever we having this patients. And the drug classes, OHA, that is very important. The first line of the therapy is the metformin, but the metformin is associated with the diarrhea, lactic acidosis, B12 deficiency. Sulfonylureas, it is highly associated with the weight gain and the hypoglycemia. Maglitatides, this is the short acting type of the potassium blockings. This is the weight gain and the hypoglycemia, but very minimal type of we are going to see. DPP4 inhibitors, this is the sitagliptin and the saxagliptin. They block the DPP4 enzyme so that the incretins will be increased in the body. But it is associated with the pancreatitis, nasopharyngitis, and the headache. Next, GLP-1 receptor agonists. These are glutides: exenatide, liraglutide, and the tirzepatide and the semaglutide. But all are going to be the subcutaneous forms only. And these drugs will be increasing the incretin. What does the incretin will do? It will decrease the glucagon. It will decrease the glucagon, increase the insulin secretion. Nausea, weight loss, pancreatitis is seen. So famous drug Ozempic is the one drug that is used for the weight loss. Next, SGLT2 inhibitors, that is the gliflozins, empagliflozin, canagliflozin. They are going to act on the SGLT2 in the renal glucose. They are going to excrete the excess glucose from the body, but they can cause the UTI and the genital infections, diabetes, ketoacidosis. Very rarely it is seen, but it is good for the heart failure patients. Weight loss is also seen in these patients. Next, amylin analogs. These are also subcutaneous type. Pra-amylitide, the name itself, it is a pra-amylitide. It will stop the gastric emptying, but associated with the hypoglycemia when it is taken with the insulin. Next, alpha glucosidase, agaribos, vaglibos, miglotilol. This is going to delay the carbohydrate absorption, but diarrhea, flatulence, abdominal pain, it is given. So IBD patients, inflammatory bowel disease patients, we should not be given. Thiazolidinidoids, it is a glitazone or the rosiglitazone. It is going to increase the insulin sensitivity, and GLUT4, it is going to act. But weight gain, edema, heart failure risk, fracture risk, bowel cancer, sorry, bladder cancer, all this will be seen with the thiazolidinidoids of the patients. Next, two complications that you have to remember. One is the patients who is suffering from the DKA, and other one who is suffering from the oral hyperosmolar hyperglycemic syndrome. First, as we discussed, microvascular eye diseases like retinopathy, neuropathy, or the nephropathy, the patient will be suffering. And macrovascular peripheral arteria, cerebrovascular coronary diseases. Another conditions, gastroparesis, complete the paralysis can be seen. Genitourinary sexual dysfunction like erectile dysfunction can be seen. Dermatological, infectious, cataracts, glaucoma, chorioarthropathy, periodontal disease, hearing loss. All these conditions can be associated with these conditions. Next, what are the two complications that I want you guys to remember? One is the DKA and hyperosmolar hyperglycemic syndrome. This is how we are going to differentiate it. This is most common in the type 1. This is most common in the type 2 patients. Young patients, okay, here the old patients. And trigger here is the UTI, and here trigger is the respiratory conditions. Okay, how much is the glucose? So the glucose is 600 plus. Here the glucose is almost 200 plus also seen in this patients. So the ketones, more and more ketones is produced. So the ketones here is not produced or even absent also. The ketones is most of the times it is absent in this patients. And here the lipolysis is seen. Okay, potassium can be low in this patients. Patient will be having dehydration. Okay, all this will be seen. Here lipolysis is minimum and potassium is normal and dehydration is seen obviously. Okay, this will be associated with the hagma. This is associated with the hagma and this is associated with the nagma. So this is the differentiating features between the DKA and also patients who is suffering from the hyperosmolar condition, right? And how we are going to treat these patients? First of all, the patient treatment has to be started as per this protocol. I have already added the picture, just you can see this picture. So for the patients of the diabetes ketoacidosis, how we are going to start? First, confirm the diagnosis, serum glucose, and also ketones and metabolic acidosis. Admit the patient. It has to be treated as a ICU care only. And first, you have to replace the fluids. 2 to 3 liters of the NS has to be given for the patients over the 1 to 2 hours. And in that, you can add this patient's insulin. Regular insulin is given. First, you have to start with the 0.1 units per kg. You have to start. But you have to check the serum potassium correction. If the serum potassium is less than 3.3, do not administer the insulin until you are going to correct the potassium. That has to be taken care because it can cause the arrhythmias and the patient can die. So these 2 points that you have to remember. Fourth and the fifth point that is important. But cause of death. So the cause of death in this patient is the cerebral edema. So most of the times the cerebral edema that is present in the patients of the DKA that you are going to see. And one disease that we have missed and we will going to discuss now, that is the Crohn's disease and the IBD that we will be discussing now. Okay. So let's discuss here guys, Crohn's disease and the IBD. So Crohn's disease and the IBD, you all know that this is the inflammatory bowel disease, right? Inflammatory bowel disease. Most of the inflammatory bowel disease is going to be the ulcerative colitis or the Crohn's disease, right? These important points, Crohn's disease and ulcerative colitis. This is an inflammatory condition. So this can be seen from the mouth to anus. It can be seen any location, but this is going to involve the sigmoid, or it can be involving only the rectum, colon, rectum. These are the common locations that is going to see. Where you are going to see the skip lesions, and here it is a continuous lesions. Okay, continuous lesions. This is going to be transmural, means all the layers is involved. Only here the mucosa plus submucosa is involved in this patients. Next, coming to the where the fistulas is formed. Transmural, all the layers is involved. Then it can form the fistula tract. Fistula tract is formed where? It is formed in the CDs. The fistula tract is formed here. Where is a polyps? Pseudo polyps is formed here. Only 2 layers is involved. Pseudo polyps. That means it is false polyps that you are going to see here. Next, skip lesions is also known as a cobblestone appearances. Cobblestone appearances that you are going to see. Which is going to have the bloody diarrhea? This is going to have the bloody diarrhea, and distension is seen sometimes. Okay, megacolon complication is seen. Megacolon complication is seen with this, and this is going to cause the granulomas and also strictures, abdominal obstruction. Okay, that is also seen with this patients. All these small points that is going to be make an important point, and which is associated with the cancer. Both are associated with the cancer. Okay, both are associated with the cancer. These are the important points that you have to take note. Fistula, and another point where you are going to see the creeping fat. Creeping fat is seen in the CD. Pseudopolyps, lead pipe colon, megacolon, that is seen with this condition. And this condition is associated with the primary sclerosing cholangitis, that is also seen. This is associated with the granulomas. Okay, what is the drugs that we can use? We can use the steroids, we can use the some of the methotrexate, azathioprine. These drugs can be also used for this patient. So this is the overall topic that we have discussed, guys. Tomorrow we will be discussing the ECG, cardio, respiratory, and other miscellaneous topics that we are going to revise. Please do revise and recall these important topics. This can be potential questions. All the PYTs is included. So those who are new to this channel, please do subscribe and share with your friends. Until then, see you guys in the next video. Happy preparation.